All right, are we live? I think I got a cue. I'm just waiting for people. Hi, I'm Dr. Sarah Levin. I'm one of our deputy health officers at Contra Costa Health Services. And we are hosting in collaboration with Empowered Aging, our renamed Ombudsman office, a series of trainings for caregivers in infection prevention and control. We were able to generously do this with a grant. We were able to do this with a generous grant from the National Association of City and County Health Officials. And we are happy to be able to bring this to you in Contra Costa County as the family and friends and lay caregivers of our elders in congregate care facilities with a focus on skilled nursing facilities and assisted living facilities. Just for a couple of housekeeping issues, we are going to be playing what we did were recorded modules from with a consultant we worked with from the National Association of Prevention and Infection Control, APIC, and Nancy Parrish. So she will be the voice in the presentation part of the video, but we have Ricky Rios Robinson and Christina Ponce, both RNs, public health nurses, who've been our go-to warriors through this pandemic, working with all of these facilities, doing on-site training and visits, and really just bringing up the level of practice and prevention efforts during the pandemic. So they are going to be hosting the Q&A after we complete the video portion. We're asking people to put their questions into the chat box throughout the presentation, and they'll be collating them throughout the showing. And then at the end, we'll address them. So please, as the presentation is playing, feel free to enter into the chat box. And then other housekeeping efforts we do when you registered, have your email addresses, and we will be using those to communicate materials and resources in the going forward, as well as to send out certifications of completion when you've completed the modules. There are 3 of them. If you were not able to make it to all of these live presentations, they will be available, and we will be sending those out as well, and those you can share with others. And we really hope that you enjoy and learn from and are able to apply all the great teachings that we are offering, and happy to be able to offer it to you. And also just want to give great thanks and kudos to our Nicole Howell and her staff at the Ombudsman office, renamed Empowered Aging, and who has been immeasurable, invaluable collaborators and partners throughout our efforts as the County Health Department to try and quell COVID-19 pandemic in Contra Costa County. And similarly, want to give that same gratitude and kudos to Debbie Toth at Choice in Aging and her staff, who have been invaluable partners. So thank you, and I'll stop there and get us started.
All right, I will be starting. Let's see here.
This is the first in a series of, this is the first in a series of 3 modules for training for families and caregivers. And we're going to go over some basics with regard to long-term care facilities and what you can do to protect yourself and for the benefit of your loved one. Now, I'm Nancy Paris, and I'm a consultant in infection prevention and control, and I've got over 40 years experience working in the field. I've worked in most healthcare settings as well as other non-healthcare settings, and I've worked on several outbreak investigations over the years. Now, the objectives of this first basic course are the following. At the conclusion of the presentation, those participating will be able to discuss the importance of infection prevention in long-term care facilities, describe the different types of organisms or germs and how they spread, and then name the main regulatory agency involved with long-term care. I'm going to start with going over some common terms because there are a lot of technical terms that we use in the healthcare setting, and this is all the different settings. And I want you to be sure that you understand what they mean. So first we have a patient. That's a person who's receiving medical or nursing care. Now, a resident is somebody who lives somewhere on a long-term basis. ADLs are activities of daily living that we see with our residents. This includes bathing, toileting, eating, dressing, and so on. And these are some of the activities that occur in long-term care settings. Hand hygiene, you're going to hear a lot about hand hygiene. This is where we clean our hands to remove potentially harmful germs. We can use soap and water or alcohol-based hand sanitizer, which is also referred to as alcohol-based hand rub or hand sanitizer. Now, organisms, these are also officially called microorganisms, but we call them germs or bugs. An agent is a term that's used a lot of times to refer to germs. Now, when you hear the word transmission, this is how germs spread. And with transmission, we're looking at contact and exposure. Contact is technically defined as people who are within 6 feet for 15 minutes or greater from somebody who is infected. And exposure is when there is unprotected close contact with an infected person or object. And you'll hear more about unprotected close contact. Now, precautions, and they're based on scientific evidence. They're not required to be followed. However, because they're best practice, they usually are. Now, one of the blurry situations that's occurred recently is that some regulations actually require compliance with certain of these best practice guidelines. So it gets a little complicated, but again, what we're going to go through in these modules is what you need to know for what you need to be doing. Now, we also have public health. The focus from public health is on prevention. Public health is there to protect the health of everybody in the community and improve the quality of life. So they're involved and have some oversight and involvement as well. So all of these groups have a combined ongoing effort to improve the safety and care of the residents. That is our goal. Now, you're also going to hear about surveys in the facility, they are occurring in most of these different types of long-term care facilities. And the purpose of them is to make sure that the facility is complying with those regulations. And it has the agency, again, for example, CMS or Medicare, Medicaid, they have surveyors who come in, they have extensive checklists, and they look at all aspects of care and the physical environment. Now, again, they may not be as extensive in some of the lower type care facilities, but there is this sort of oversight everywhere. Now, at times, they will involve residents in their surveys. They may come in and ask your loved one. They may ask you as a visitor or care provider about some questions about what is happening in the facility. It's okay to participate. And the facility itself may do what we call mock surveys, which are really practice surveys, but also it's their validation that they're compliant. It's their making sure that they're compliant. Now, there's another type of group that's involved, and that's an advocacy group. There are many of these, and their purpose is, again, to improve the quality of life for long-term care residents on whom they speak. Now, they investigate and resolve complaints. They may also be the ones to identify problems and maybe recommending changes in federal, state, and local legislation. Also, they may have input into the regulations and guidelines. So with all of these different agencies, different groups, the bottom line is they're really looking out for the benefit of the residents in the facilities. So the facility has special responsibilities with compliance, which I've mentioned. And what we see is in most long-term care facilities, they're going to have, among other ways to assure compliance, an infection prevention and control program. Now, a skilled nursing facility, for example, will have a fairly sophisticated, involved program for the facility. A board and care, it will be less formalized, but it will still be there because they will be watching to assure prevention of infections in their residents. Now, the objectives, overall, it's to prevent transmission of infections from virtually anybody to anybody. Staff to resident, resident to staff, resident to resident, and even staff to staff. Within the facility, and this could be formal or informal, again, based on the type, there will be policies and procedures that they will establish, educate everybody on, and monitor to make sure they're compliant. And again, the degree of this depends on the type of facility. Everybody in the facility, all staff and departments will be involved, and there will be someone who is overseeing or facilitating this program. Now, it could be someone at the leadership level, the administrator, the nursing director, and this is typical in the smaller, lower level of care type facilities. In skilled nursing facilities, nursing homes, they may have what's called an infection preventionist, who is one individual who has responsibility for oversight of the program. And that's where they're going to have a more formal program set up. Now, in addition to the facility's responsibility, you have personal accountability. You have a role in this. And this includes, first, complying with the facility rules, especially those involved with infection prevention. As visitors, but as also a caregiver for the resident. You're not staff. You're not considered staff. And one mention is sometimes the facility will want to count you as staff, but you need to realize you are not considered staff for that purpose. You were there to help with the care of the resident in many ways. And you need to comply with the rules, and you'll be made aware of whatever rules you need to know. You also need to understand the constraints and the risks of congregate living. This helps with complying with the rules and keeping everyone safe. Now, this will be mentioned again, but if you're sick, stay home. You need to understand how germs are spread from person to person, and that's going to be reviewed in this module. You going to have to practice good infection prevention, and in these modules, you will learn how you can participate with this. Use good technique with wearing personal protective equipment. This will be in the second module of these classes. And then support a safe and healthy environment for the resident. It will be for their benefit and for your benefit as being there. Now, what's important is if you're uncertain of anything, ask someone for clarification. Don't second guess. Don't try and figure it out. If you're not sure, just ask. There's no such thing as a dumb question. So we take the personal accountability along with the facility responsibilities, and what we end up with is safer residents and actually safer staff and everybody. So that's basic long-term care information. And I'm now going to talk about understanding infections. I'm going to talk about germs, how they spread, a little bit about how people get infected. So I always start with the chain of transmission. And remember, transmission is spread. And what's important here is that we have all of these elements that need to be present for an infection to occur. It isn't just where there's germs and that's it. People get infections. You need all of these elements, and I'm going to walk through them. So you need a germ or an infectious agent. Reservoir, this is where these germs exist, or their home or their habitat. Now, there's got to be a way for the germs to leave that home, a way for them to get from that one home or resident to another, a way to get into somebody's body. And then you need to have a susceptible host. We call it susceptible person. This is a person who is susceptible to those particular germs. And not everybody is susceptible to all germs. There are various reasons. So the objective here is we want to break this chain in every opportunity that we have. So I'm going to go into a little bit more detail about the chain. A susceptible host is a person whose susceptibility is based on prior history of infection or immunization to that particular germ. So somebody who had, let's say, influenza may have some immunity, but also with that, every year we have different influenza germs. So they may not have protection to that particular new one, and there may be more susceptibility. Now, there's also an impact of the immune system on somebody's susceptibility. Someone who has a very robust immune system may be better to fight off a germ than other people. And what is considered a lesser ability to fight off infections is the elderly and newborns, or very young. Those have either immature immune systems or immune systems that are just kind of slowing down. And there are other factors than age that affect an immune system. This would include underlying illnesses such as cancer, medication, which could include cancer drugs. It could include a lot of other types of medication, and also malnourishment. So different variables make somebody more or less susceptible to different germs. Next, we have the agent, the germ. Now, there are many different types of organisms, and I'm going to mention a few general types that we see in long-term care. One of the most common is bacteria. We also see viruses. We'll see a fungus. A fungus or fungi, which is the plural, is really important in long-term care because where we have susceptible people, there are some that this unique population, by being older, is far more susceptible. So there's a lot of care that may need to be in place with these types of organisms. Now, parasites, this is a scabies mite, which we do see outbreaks in a lot of types of congregate living situations because of the way it's spread. And so it's something to be aware of. And then the last one, a prion, and I'm not going to mention it other than it is one that is rarely involved in long-term care, but it may be. Now, with regard to these different organisms, I'm not going to give you a microbiology course. I'm simply going to mention that there are big differences. The general public tends to think a lot of times that anything is a virus, and that's what diseases are caused by, but everything isn't. And the differences include the characteristics of these different organisms, these different germs. They have very different characteristics between them, which affect their ability to infect people and cause disease. Now, what's also important, and you're going to get a little bit more of this in Module 3, testing methods are very different depending on what type of germ we're looking at. So the tests that we do for bacteria, for example, will not usually pick up a virus. They're going to be very different tests, and the physicians know what tests they want to use depending on what the germ is that they think they're looking for. And then again, the treatments are going to be very different as well, depending on the type of germ. And what's important here is everybody thinks antibiotics are the be all end all, and antibiotics are great, but antibiotics don't treat viruses, for example. We use what are called antiviral agents. So treatments are established based on the type of germ that we're dealing with, and it's important to have a good understanding of this. And again, we'll get more into this in Module 3. Now, next we have the reservoir. And this is the natural habitat in which that germ normally lives, grows, and multiplies. And this could be humans, could be also animals and the environment. And it also may not be the source from which the agent is transferred to a host. There are some germs that lived in the ground, but we may get them from another person that has become infected. And so there's a lot of differences here, and that's simply where those germs will survive. So now we have to have a portal of exit or a way for that germ to leave that host or leave the reservoir. Now, when it's a host, when it's a person, it will usually correspond to the site where that germ is. And here are some of the most common portals of exit. The skin. So anyone with broken skin or cuts in the skin, that's an opportunity for those germs to leave their body. Infested skin. I mentioned scabies. Someone who has scabies has skin that is infested with these mites, and that would be a portal of exit in those situations. Also, contaminated hands can be a portal of exit. The respiratory tract, sneezing, coughing, respiratory secretions, saliva, anything coming from the respiratory tract is considered a portal of exit. And the gastrointestinal and genitourinary tracts are portals of exit with stool, vomit, urine coming from those portals that could be potentially infectious, harboring germs. Now, medical devices and instruments contaminated with blood or body fluids can also be considered a portal of exit. And I'm going to mention here that little picture is a glucose monitor. And what's important with this is a lot of our residents will have diabetes and will be being treated and monitored for diabetes. Their blood sugars will be monitored routinely using these devices, and you may be working with them. These have been associated over the years with numerous outbreaks, and it's important to realize that if you're handling them, be very careful with them. Dispose of the lancets or the devices that prick the finger. Dispose of them properly as instructed by the facility, and make sure that the device is disinfected after every single use. That is important to be aware of, and I'm just going to mention that here because it's just a little important sideline. Now, next, we have to have that portal of entry. So it's a little bit of the flip side of the exit. This is how the germ enters the susceptible person and has the potential of causing disease and infection. And this could include skin. So broken skin, cuts in the skin, if you get organisms in, germs in, a person may end up with an infection. I'm going to talk a lot about the mucous membranes of the mouth, the nose, and the eyes. Those are important with regard to transmission or spread of many, many germs. Now, the respiratory tract also is considered a portal of entry, and this is a little different from the mucous membranes of the mouth and nose because we're talking about getting into the lungs, not just in the mouth and the nose. An organism, a germ may enter the respiratory tract first by getting into the nose and mouth, and then go deep into the lungs. Then last of all, we have the gastrointestinal and genitourinary tracts again, and this could be with the gastrointestinal tract from eating food that's contaminated and one gets infected. So last of all, we have to have a way for those germs to be transmitted or spread from one person to another person. So usually they're transmitted most commonly by contact, what is called contact transmission. And this is divided into two subgroups. One is direct and one is indirect. Now, with direct contact transmission, the germs go from one person to another person without anything in between. So again, I mentioned scabies. And with regard to scabies, if you have somebody who is, and again, it's called infested with scabies, and another person has direct contact, skin to skin, they may become infested from that person. So it's directly from one to another. Now, also, if somebody gets blood from one person into, again, broken skin, that would be a way that this transmission occurs. And then again, the mites, as I mentioned, from scabies getting onto unprotected skin. Now, the exit, the portal of exit with this is broken or infested skin. And the portal of entry, depending on what the organism, the germ is the mucous membranes, which I mentioned, or breaks in the skin. And it all depends on the germs, the infections. Now, indirect is very similar with one big difference. There is an intermediate object or person that comes into play. So this is where we could touch a person, and then we don't perform hand hygiene, and I'm going to get a lot into hand hygiene in the second module. And we carry those germs from one person to another person. Or it could be, as I mentioned, with the glucose monitor, that we use contaminated devices and they're not cleaned and disinfected after every use, and they could cause transmission or spread of germs. Now, the portal of exit is through the contaminated hands, the devices, or with healthcare workers with instruments. And again, the entry is the same, mucous membranes or breaks in the skin. Now, there's another mode of transmission called droplet. And with droplet transmission, this is where we see respiratory droplets that carry those germs. And transmission occurs when those droplets go directly from one's respiratory tract to another person's mucosal surfaces. Again, that's the eyes, the nose, and the mouth. Now, droplets generally travel short distances, and I'm going to explain a little bit more to clarify droplet in a few minutes. The portal of exit is coughing, sneezing, talking. It could include also singing, and even heavy, deep breathing, and also what we call aerosol-producing procedures. Now, I'm going to explain this term a little bit more, but originally it was felt to be certain medically induced procedures that were performed by clinicians and caused aerosols to occur. What we recognize now is there are instances where we can actually, with a really big sneeze, propel droplets and create our own aerosol producing activities. But again, I'll explain this a little bit more. Now, the portal of entry is the nasal mucosa, or the nose, conjunctiva, or the eyes, and the mouth. This is how they enter somebody's body. Now, a lot of people get confused between droplet and airborne, and it's very different, although it seems similar. This is where, instead of those droplets, we have what are called droplet nuclei, or very small particles that contain the germs. And with these, they travel long distances by air currents. They can remain infective or able to cause infection over long periods of time. And what happens is the susceptible people now inhale these droplets. They go into their lungs as opposed to just the nasal mucosa, conjunctiva, or the mouth. Face-to-face contact is not necessary for spread to occur. Now, the portal of exit is going to be the same as with droplets, and here it also mentions singing and talking, but all of them pertain to anything coming out of that respiratory tract. But the difference is the entry gets into the lungs. So these are germs that if they get into the lungs, that's when we have the risk of airborne transmission And they're very different, and we'll get into what we do with this later on in these modules. Now, I said I was going to explain airborne, droplet, and aerosols a little bit more, so I want to put it into a little bit different terms. Because with COVID, a lot of terminology was used by a lot of different people, a lot of different groups, and it became very, very confusing and blurred. So I want to see if I can unblur that a little bit for you. Airborne, again, is where you have those tiny droplet nuclei that get in the air, they spread with the air currents, they go long distances, and they can remain in the air. Now, this is using a flower analogy, a dandelion, where we see the little particles that if you blow on the dandelion or you shake it, these will get into the air and you'll see them drift and go with the air currents, and they can go for long distances. Now, droplet, using this same floral analogy, is where you see the petals from the flower that fall off from, again, it could be shaking or they just die off, or you blow on it, and they'll drop to the ground. They're heavier. They're not going to stay in the air. They can't stay in the air, and they will just drop. Now, the third is aerosols. I don't have a floral analogy, but this is where those droplets can be made into more of an airborne type germ by a propellant. So what you see here is with this spray can, we're spraying and we're forcing those droplets into the air. So if that happens with our droplets that some germs are contained in, it can actually get them in the air, and it can spread them a bit further, and it could keep them in the air a bit longer. The heavier ones will fall to the ground ultimately, but this creates a bit more of a concern and a risk. Now, there was a paper that was presented at an international conference in April of 2021, and I want to acknowledge the presenter and author, Hilary Babcock, who is a physician. And this is a paper, a chart from a paper that she presented, and I'm going to make it a little bit more simple for you. It was really important because what she did is she was describing that the confusion that we see is actually because there are terms, airborne, aerosol, and droplet, that clinicians use and have a certain understanding. Now, the general public has a very different understanding than the clinical terms, and that makes some confusion when these terms are used. There then became the aerosol scientists or engineers who got into the fold when we saw a lot of communication during COVID, and they also defined these differently. So when you have the three different definitions, everyone is confused, and there was a lack of understanding of what was really what was what. So I'm going to start with droplet, which is a particle that is larger typically than 5 microns. It's still very small, and they fall rapidly to the ground within a distance of 1 to 2 meters from the source. That was where I described that petal from a flower or somebody sneezing. Usually those droplets only go a couple of meters, then they go to the ground. Now, the general public thinks of droplet as meaning that which comes out of an eyedropper. So it's a foreign term really to them. And the aerosol scientists look at it a little bit different from all. Now, we then get into airborne, which again, this for clinicians has always been that long distance transmission, staying in the air, and it's smaller particles. And we see this with measles, chickenpox, pulmonary tuberculosis, and a few other infectious diseases. And the problem is that the general public understood this as being anything in the air, but it isn't. And aerosol scientists also understood it the same way. So there's a big difference between airborne and droplet, and the general public has been confused. So hopefully this will help get rid of some of that confusion for you. Now, an aerosol plays a very special role that we learned a lot more about during COVID. And this was studied a lot by the scientists the aerosol scientists in a lot of publications that just confused everything. But this is where you have smaller particles than the big droplets. They're less than 5 microns. But what they do is they mediate airborne transmission. And that means out of those droplets, there may be some smaller particles that normally would simply drop to the ground. But during a situation where there is I'll call it a propellant, an aerosol generating procedure, a sneeze, a really deep cough, or even somebody singing where they're really projecting their voice in the singing or talking, they're propelling. And this can mediate or cause more of an airborne transmission. Now, the germs will not travel the same sort of distances as with true airborne transmission, but they can go further. And that is one of the problems and situations we see. Now, the general public understood aerosols as being simply using hairspray or other personal or cleaning products where we spray and it goes only so far, and we do that. But in terms of healthcare, aerosols play an important role in understanding transmission. So again, airborne is the small droplet nuclei that travel far distances. Droplets are larger particles that drop, and aerosols are where some smaller droplets can be put in the air for longer distances and for a little bit longer periods of time because of aerosol generating procedures. So what we want to do is just go back to how these germs are spread, and you'll hear this repeated in these 3 modules because this is the basis for prevention. This applies to when you're in the skilled facility, the long-term care facility with your loved one or your resident. It also applies to when you're at home and your daily living, because we want to always be protected. So use common sense. Keep in mind what I've just gone over with how germs spread, and do what you can to prevent the spread. So touching your nose, your eyes, your mouth. If your hands are contaminated, you can be spreading any germs that are on them to your nose, your eyes, your mouth. You may not end up with an infection, but you may. So keep that in mind and be careful about not touching. Now, also, there are germs that we can become infected with through food. And this could be either from food that's been contaminated when it's being prepared or handled, but also eating the food or drinks, having unwashed hands where we can contaminate the food. If we eat food like a sandwich with our hands and our hands are dirty, or contaminated, we can end up ingesting or eating those germs. Somebody who is preparing food, and not to be really gross, but if they used the toilet and did not wash their hands following using the toilet, they may contaminate the food by having contaminated hands. Touching a contaminated object. Now, this is a pretty grossly contaminated area. Hopefully we're not going to have that, but sometimes usually you're not going to see what's contaminated. So if there are areas that we think may be contaminated, we need to recognize that we need to clean our hands following touching those areas to keep the germs off of our hands and out of our bodies and out of our residents' bodies. Now, in the second module, we're going to talk more about this, blowing your nose, or if you're coughing and sneezing. One of the things is that if you're blowing your nose or coughing or sneezing into your hands, then your hands become contaminated. So they need to be cleaned prior to touching other people, other people's hands, common objects, anything else. And even if you're using a tissue, the tissue needs to be discarded and hands need to be cleaned. So most germs are spread from contaminated hands or directly from droplets. So we want to keep our hands clean, contain our droplets, and keep the environment clean and protected from being overly contaminated. So think about how germs spread in order to look at how you can prevent their spread. And the takeaway is many agencies have oversight over long-term care facilities and perform surveys to ensure compliance, and all of this ends up in keeping the residents and you safe. It's important to understand how germs spread and cause infections, because that way we can participate in preventing their spread. And hand hygiene, one of the basic and most important and effective means of preventing the spread of germs. Practice often. So that is the end of Module 1. Thank you for your attention.
So everyone, that was a great presentation, and I'm sure we have lots of questions. We did have a minor technical glitch, so we're going to be sharing the video with you all later on, the first few minutes, but I'm sure you have questions about what you learned, and we have 2 nurses here with us, along with a physician who was able to answer our questions about infection control. And remember, this is to prepare us all so that we can be better caregivers, be that a professional caregiver or a personal caregiver for our friend or family member. So start dropping your questions in the chat. In the interim, I'm going to turn it over to Christina and Ricky to teach us a little bit more.
There are no questions in the chat. Dr. Levin, is there anything you would like us to talk about?
So I just want to, as Nicole acknowledged, there was, when we were trying to expand the screen, I think we did a skip of about the first few minutes where it was defining some of the terms that she was starting to make at the beginning. And so there may be a disjuncture there for people, because that was some of the foundational basic terms. I don't know if that's something that, if we don't have questions in the chat, we should try and play that piece, or if that's something, what do you think?
Can you hear me?
Yep.
Yeah.
Okay. Yeah, we can either replay the first several minutes, or, and I know that the beginning of the presentation, it does define terms that I know that were really confusing for me when I started visiting these outbreak facilities with Christina. And one of the terms is a board and care home. We would go to board and care homes, assisted living facilities, and skilled nursing facilities. And they're all 3 different types of facilities. Our board and care homes typically are 6 beds and under. And they're residents who reside inside of a home. And then we have the assisted living facilities that we also visited. And these are also residents that that's also their home, and some of them may live independently, and then others may need assistance with activities of daily living. And then we also went inside skilled nursing facilities, and they also, that gets kind of dicey too, because inside a skilled nursing facility, you have residents who live there long-term, but then you also have patients who are receiving some sort of medical care, and they might just be there temporarily. So I hope that that kind of clarifies what these facilities look like. Are there any questions there?
And then Nicole, is there any chance, if they're having a hard time, if somebody doesn't really know how to use the chat, are they able to come up off of mute to ask their question, or they can't do that?
It's sort of an all or nothing situation where, like, if we take them off mute. So what I maybe would say is, if I think, oh gosh.
I think we have plenty of time. So and there's a few enough participants that I think I'm okay. I think, and Ricky and Christina, you okay with taking them off mute, all or nothing?
Of course.
Okay.
Sure.
Okay, so I'm just going to take for the phone numbers. I'm going to ask you to unmute, and if you have a question, you can go ahead and offer it. If not, please, be mindful of the feedback. So if you're on the phone, you're able to ask questions. And Dr. Levin, I do see a question in the chat from Debbie Toth.
Yes. Debbie is asking if I could provide an update on the visitation standards currently, and who is allowed and where do they reach if they need help. So currently there are no limitations on visitation in terms of the policies that are coming. The county has not enacted any additional policies limiting visitation that are in addition to what the state, California Department of Public Health is, and CMS is limiting. And in fact, what is clear is that every facility needs to allow visitation with clearly with still the infection prevention and control standards that may determine the policies around mask wearing and contact. But I just want to say that one of the foundational parts of that is that people, residents in these facilities, need to be allowed to have visitation from their loved ones. At the shortest the visit can be is 30 minutes. So that's the bar that has been set by the state and by, everyone as residents of these facilities should be accommodated to be able to receive their friends and loved ones for a visit at a minimum of 30 minutes. The facilities do need to be able to keep everybody safe. So they have to figure out their own policies around scheduling those and how many people can be in the facility given their particular circumstances and space. But that is a minimum standard, is that people should not be asked to do a visit less than 30 minutes. There is currently still at this level a mandate that these facilities need to be treated the same way that we're treating public transportation or healthcare facilities, which is that they, even in the non-healthcare facility, residential facilities, so the congregate care facilities, the assisted living facilities, and the board and cares, which is that masks are mandatory, not optional. And there are, there is language around that where if both resident and visitor are vaccinated, they can share unmasked space and share meals. But the general milieu of the environment is one where, just like if you were to enter any public transportation, you're assuming that you're wearing a mask, visitors and staff. Christina or Ricky, do you have anything to add to that?
I was going to just say we had a bunch of questions regarding the not wearing masks in common areas if they're visiting, say, in a library of an assisted living. And if you're in that common areas, that's where you were saying that it is important. Everybody still needs to wear a mask in common areas. So that unmasked option for both vaccinated parties would be inside their private room with no roommates, correct?
Yes.
I've gotten that phone call about 6 times this week. So I know that's definitely a question that's out there. They're just not asking.
Yes.
And I just want to add that I believe that the masks are just so important. Christina and I do outbreak visits at all of these facilities, and it's extremely common, especially lately with the vaccinations, that we might have just one positive resident and no positive staff. And so that leads us to believe, okay, well, how did this resident test positive for COVID? And oftentimes it's because they had a visitor that maybe, visitors don't always follow the rules. And so it could be that they had a visitor that took off their mask, or also residents are leaving these facilities and going out into the general public. And so that's not uncommon for us to see. So it's just really important to continue to follow those guidelines, especially with this a more vulnerable population. So masking, I don't see that changing anytime soon.
And let me just add to that, Ricky, that like one of the things that we really learned in this pandemic is that like what happened with flu, we saw virtually no flu in this season, in this year, which, like usually what we're seeing is 120,000 hospitalizations due to flu, up to 20,000 deaths depending on the year. And it was essentially nothing. And that was because of the practices of mask wearing is really the best conclusion from that. So I think one of the things we all need to really think about is like maybe like our Eastern partners, human beings who've adopted this for a long time, we need to be a little bit more rethinking about how we practice public congregation with each other. And so I'm gonna just put that out there for people to think about. And I think, there's a lot of, in this country, obviously, sort of connotation, unfortunately, around sort of what masks meaning. And, there's a lot of people who are vaccinated who are continuing to wear masks, including many of the people in the public health department when they go into public spaces. So I think everyone needs to do a self-assessment about what they feel comfortable with their risk. And it certainly is safer to do that in places where there's more vulnerable people. So that's my soapbox.
Definitely. I'm there with you. Masks work. So I will continue wearing mine.
So maybe Ricky or Christina or Dr. Levin could talk to us about how this is going to build on for future lessons, that this is sort of a three, not really a drop in, it's more of a part of a three-part series. So maybe you could tell us a little bit about that.
Sure. So, right. So this is the first module of a 3-module series, and this was supposed to be, the first one is really just sort of the basics in infection prevention and control, to try and orient people to the language, the definitions, some of the basic principles. So it's basically like a crash course in infection spread and epidemiology of infection. And we hope that it makes it accessible to people who don't have an advanced degree in healthcare settings. So I hope we were successful in that, and I hope that you're able to share it. The next 2 series are really trying to get a little bit more specific on sort of within congregate care facilities and what are the best practices in terms of personal protective equipment. Why were we using, this type of protection equipment in, certain settings and not in other settings? So trying to break it down a little bit more in a granular level on sort of why if you're going as a caregiver to visit your loved one in a facility, why there may be a green zone where you don't, all you have to do is wear a mask and you don't have to wear anything else. But in another setting or time period, depending on what has happened at the facility or with exposure, you may have to wear a little bit more because you're in a yellow zone and it's a higher risk or it's a quarantine situation. So it's going to go a little bit more. The second module will go a little bit more into that. And then the third module is, I think, a little bit more a bird's eye view of not just sort of those personal protective equipment and sort of that and what we're doing in terms of cohorting of facilities, but more again of sort of the a little more depth on the different types of infections beyond COVID. Which she touched on a little bit on today's module, but we'll get into a little bit more. And I think the hope here really is to empower all of the lay caregivers, the family and friends who provide regular care and protection for their loved ones at these facilities, the tools and skills and knowledge to be able to feel like they can appropriately care and advocate for in a safe way. And I think the other thing that the third module has in it, which I think there may be some more questions about, is there's some nuances in infection control around sort of treating infections because of the development of antibiotic resistance. And so we hope that by the third module, you'll feel like you've gotten enough knowledge that you're sort of able to understand some of why it's not so cut and dry or black and white when it comes to the specific individualized treatment of a given person in a facility who may be defined as having an infection, and sort of that distinction between being actually infected such that it's causing something that needs to be treated versus they're colonized and you don't want to give them antibiotics because it may develop antibiotic resistance, both for that person individually, but also at the larger community level.
So Dr. Levin, what if someone on the call is like, oh my gosh, this is great information. I would love my neighbor who has a mom in a facility to be part of this, but they weren't on today's call. Can they join halfway through, or is this a like you got on the bus or didn't get on the bus kind of thing?
No, totally can join halfway through. I think that's the point of really making the links available. We'll make it available on our county website so they can catch up with the modules. They don't ever have to attend one of these sessions. They can watch all 3 modules on their own. What we are hoping with the advantage of having us live on these sessions is just that you can get some of your questions answered. You could watch the first module before the next one and come back at us next time with questions from that one. So I think we're just trying to create some space to ask through some of the concepts or the teachings that may be confusing and kick it off so that hopefully we generate some interest with the idea that many more people than who come to these sessions will actually use the modules and the teaching.
And I just realized we have a habit in medicine to use, and in public health to use fancy acronyms. And I just realized that some people might not even realize what PPE stands for. It's personal protective equipment. You may have heard that, you may have heard those letters quite a bit. So what we can even do, we will be discussing personal protective equipment, PPE, next week. And we can even model for you or show you the proper way to, we say don, which means putting on your mask, and then doff, which means taking off. It sounds super simple, but there's really a method to the magic, and there's a way to do it safely to prevent the spread of germs. So we can, that sounds like someone in the chat had that idea, and I think that sounds really exciting.
So I want to do a last minute call for all your questions. Remember, they'll answer anything. If they can educate Debbie and I over the last year and make us not quite experts, but at least proficient in infection control protocols. They can do anything. So I want to encourage you to drop your questions in the chat and come back for the next session, which is next Tuesday at the same time. We'll also be sharing the recording with all of you. And we encourage you to invite either your fellow colleagues who are professionals in the field and the family members whom you work with as well to jump on this. This will help us to protect everyone, both the resident, the staff, the family members, and make us all stronger if something happens in the future. So I really want to encourage you to invite a friend. So if there are no questions in the chat, Dr. Levin, do you want to sort of give us some parting words?
Sure. I mean, mostly I just want to thank you, Nicole, and Empowered Aging and Choice in Aging, Debbie Toth, for really being such amazing partners for making sure we can do this work for Contra Costa County in this pandemic times, and just want to, again, as you said, encourage everybody to share this with 5 friends so that we can, I mean, our hope with this series was to really do a kickoff to hopefully make it slowly trickle out to the larger communities. So please share and encourage people to jump in at any time, and remind them that you will have the resources of our astounding nurses, Christina and Ricky, and myself as a deputy health officer in these next couple weeks coming up. So thank you.
All right, well, thank you, Dr. Levin. Thank you, Christina and Ricky, as well as Debbie from Choice in Aging and everyone at Contra Costa Health Services. We will be here next Tuesday at 6 o'clock, and we hope everyone has a lovely evening.
Thank you, everyone.
Good night.